Okay, today's topic is neurological disorders in children. Generally speaking, with neurologic disorders, they can be either congenital physical defects, such as you see with the spina bifida or myelomeningocele, or they may be acquired problems, such as we see with seizures. Also, they may occur secondary to infections, such as meningitis. The one thing that is understood is that it affects all ages of children, all genders, it doesn't matter boy, girl, it doesn't matter, and all races. And the common thread with any of these disorders is that it affects the child both mentally and physically. The types of disorders I'm going to talk about are first the congenital ones, and that would be hydrocephalus and spina bifida. The acquired ones would be our seizures, our cerebral palsy, and head injuries. And then infectious processes, there are two of those, meningitis and Rye syndrome. With hydrocephalus, and I realize this is not really in your book, it mentioned it, but it wasn't as a true topic, but I wanted to make sure that y'all did have a good understanding of this. This is evident either at birth or it can occur later in life, but what happens is that there is an over excess or an over amount of fluid in the ventricles of the brain, and therefore it causes the ventricles to expand or get larger. Some of the reasons we see for this are obstructions, such as with brain tumors. They obstruct the flow of the CSF. There could be other anatomical abnormalities in the brain that's obstructing the flow. Or in some cases, it's just simply the child produces too much CSF. A lot of the risk factors associated with this would be things such as being born with spina bifida, having a brain tumor. This would be something we would see later in life. Or in a lot of our preemies, they have intraventricular hemorrhages, and this can actually lead to hydrocephalus also. As far as what we see in a child that does have hydrocephalus, first they're going to have bulging anterior fontanelle. The sutures will be widely spaced in this infant. And if you look at the actual scalp itself, usually the scalp veins are quite distended because the skin is stretched. They also will have increased head circumference. If you're measuring a baby's head circumference, it will be larger. They will have a headache, which in an older child they can tell you about, but in a baby, they're simply going to cry. And it's a very shrill, abnormal sounding cry that goes along with this. Obviously, they may have altered mental status, very lethargic or very irritable. They may have vomiting secondary to the increased ICP. In an older child, they will have altered vision. They will report to you that things look kind of blurry and double to them. Usually what they have is diplopia. And then the vital signs themselves may also be elevated: blood pressure, heart rate, and respiratory rate. The way we diagnose hydrocephalus is through ultrasound before birth. Many of these children can actually be identified in utero, so it can help us prepare for treatment after the baby is delivered. Also, a woman who has a baby may have an elevated AFP during the pregnancy, especially if it's related to having spina bifida. And any child that we suspect with hydrocephalus, we will do a cranial ultrasound after that baby is born. And obviously the definitive would be doing a CT scan, but in many babies, it's just a confirmation. We pretty much know that this baby does have hydrocephalus. We can also do an MRI or a As far as treatments for these children, there's two two ways to approach it. One is surgical, and the other is medically through either spinal taps or giving the child medications that will reduce the production of CSF. But in most cases, what we see used, unless it's a very mild hydrocephalus, and we're hopefully maybe the child will equilibrate on their own, we will go ahead and do the surgery. And what you can do is, if it's caused from a brain tumor, we will go in and remove that tumor. But in most cases, what we're going to end up doing is the first thing, and that is an insertion. In this slide, I'm showing you the types of shunt that I just discussed. That's the ventricular peritoneal and the ventriculoatrial shunts, and how they are positioned in the brain itself, looping several bit of the tubing into the brain and in the ventricles, and how they put it down into the abdomen, or like I said, it would go into the right atrium. And this slide simply shows you how they do the surgery. They will open up at the top, on the top of the head, and put the shunt tubing into that, give several loops to allow growth, and then they will thread it under the skin, behind the ear, back down, all the way down to where you can. Regarding nursing care of a child who has hydrocephalus, preoperatively, we're going to monitor the child's head circumference every day. And I'll be very honest, in most cases, these children do go to surgery fairly quickly. But if for some reason the child does not go to surgery within the next day or so, we're going to continually monitor the head circumference. And we're also going to be looking for signs of increased ICP in the child, such as change of level of consciousness, irritability, lethargic, those sorts of things, as well as changes in the actual vital signs themselves. Skin care, because of the fact that the children have large heads and the skin is stretched, they're prone to having skin breakdowns. So we usually put them on things like a soft padded bed, or some type of padding under the head to keep that from happening. No pressure points. As far as nutrition and hydration, since they usually do go to surgery fairly quickly, I usually will just start IV fluids on them to keep them hydrated. If for some reason that they are not going to surgery, we may start them on some feedings, but usually we'll just put an NG tube down or an OG tube and give them feedings that way. Post-operatively, once they come back from the shunting, we're going to position them on the side opposite of where the shunt is. We're also going to, of course, give them antibiotics. That makes sense. If you're going to be doing brain surgery, they definitely need antibiotics. Then monitoring that child for signs of infection or leakage along the suture line on the scalp. If you see moisture, you want to make sure you determine what that is. Is it CSF, IV fluids? If it's a little boy, maybe he peed on himself, whatever. So what you would do is test the fluid, looking for glucose in it, because glucose will be about 2/3 of your serum glucose. So if it shows up positive for sugar, you know that there's a problem here. Obviously, urine and IV fluids would not show up with that large amount of sugar. Looking for signs of obstruction, which will be a little bit later, change in levels of consciousness, noticing that suddenly the head circumference is not getting smaller, but now is getting fuller, or the fontanelle looks full itself. As far as discharge teaching, they'll be in the hospital probably maybe a week, something like that. While they're in there, we're talking to the parents how to manage them, how to hold them, feed them, those sorts of things. And then discharge teaching would include things like the child, as they get older, not participating in contact sports, monitoring that child, basically that the parents monitor to see if there is any change in level of consciousness or change in behavior, because parents become very